Good evening, good morning, and good afternoon from wherever you are in the world. On behalf of the Parekh Family Foundation, it's truly an honor to welcome you all to the 24-hour Global Foot and Ankle Town Hall. What we are about to experience is something unique. Not just a meeting, not just a conference, but a continuous global conversation spanning continents, time zones, and perspectives, all focused on one common shared goal, improving outcomes for our patients. As we go through this meeting, I want us to be grounded in something very simple but important. Every complication we discuss is not just a case. It's a person who trusted us, a decision that mattered, an outcome that didn't go exactly the way we planned. Because every discussion we have over the next 24 hours is an opportunity to get better from the lessons we've learned from these complications. This is where this meeting is different. We're not here just to present perfection. We're here to learn from reality, real complications, honest conversations, and practical solutions. This is not passive learning. This is an active problem solving. Take something from this meeting, anything, and apply it to your patients tomorrow. This format, 24 hours nonstop, it's intentional because complications don't happen on a schedule and they don't respect boundaries or geography. Over the next 24 hours, we will hear different perspectives and approaches. When we learn globally, we improve locally. So as we begin, I want to take a moment to thank all of our sponsors who you'll see scrolling below. I encourage all of you to stay engaged, ask questions, challenge ideas, and share your experiences. The value of this meeting is not just in the speakers, but in the conversation that happens amongst all of us. And remember, we don't just treat complications, we learn from them together. And with that, Alan Yan is going to kick us off. Thanks.
Oh, hi, everyone. Welcome again to the 2026 Global Discussion Conference Online. And this year's our topic is Dear to All Our Heart. And Selene has introduced really well, and we're going to learn from all of our experiences. I'm Alan Yin. I'm your local host from North America, from South Dakota, Sioux Falls, Midwest, USA. And so our first session we started kicking off is the total ankle complications and challenges. And our session leader is Dr. Jim Lachman, who is my alumni from Duke. And Jim is, if you are looking for someone who is passionate and really love the challenges of the complex joint surgery, he's one of them. And Jim is trained with Jim and Mark from Duke, and I think he is aspiring to be one of the Jim in the future. And here we leave to Jim to introduce his group. And Jim, so you're on.
And thanks, Selene, for the opportunity here to put together this hour. They kind of gave me free reign to put together the hour. And so if there's any complaints, I'll take them in the back of my woodshed here, behind the woodshed in Doylestown. So if there's any complaints, you can come and see me directly. But anyhow, I've got a great panel here. Jensen Henry from New York, from HSS. I've got Dave Pedowitz from Philadelphia, the Rothman Institute, and then Andrew Hanselman from Durham, Duke. And so these are some people that do quite a bit of total ankle replacements. And so we'll talk a little bit about ways to avoid complications and then go over some complications at the end of the session. So without any further ado, we'll go right to Jensen.
Thanks so much, Jim. And like all things, and when we do virtual, please someone shout at me if there are issues with audio or video here. Even though it's been 6 years since COVID, I feel like sometimes it's still a game. But again, thank you so much to everybody. Thanks to Dr. Parekh and everybody for hosting. Really excited to be part of this. What I wanted to talk about is a topic that I haven't seen a lot about yet, and specifically problems, challenges, and complications during total ankle, specifically dealing with PSI and standard instrumentation. So the question for me is really to PSI or not to PSI, and when it can get you into complications, when it can get you out of complications. Just a few disclosures. So these are the different industries I have relationships with. But I think also just important as we go through this, I'm generally someone who uses a stemmed implant on the tibia, and I'm generally someone who uses standard instrumentation. So I do come at this talk from that bias. So I'm really interested to kind of hear different perspectives as we go through this. So I think, we just talked about my bias, but it's also really important to understand my perspective, at least. And this is one perspective. But to me, I think PSI, or patient specific instrumentation, it's just like standard instrumentation, it's a tool. And just like any tool we have in the operating room, it has pros and cons. And those pros and cons can help or hurt you in surgery, depending on what you know about your tool and depending on how you use it. And so, as we all know, some of the differences, PSI is very common out there. It's very popular. Standard instrumentation has a variety of different frames, the affectionately dubbed Big Bertha on the right side for one of the common implants used. So we certainly know some of the pros and cons that are commonly pointed out in the literature. So we'll talk about those first, but I'm not going to spend a lot of time on this. I really want to dive more into cases. But if you specifically look at one implant, the in-bone, when they look at the PSI versus the standard, there's really no difference in terms of tibio-talar alignment post-operatively, no difference in deformity and correction. Implant sizing, we know that PSI is probably a little bit better on the tibia than it is on the talus. Some studies have shown that fluoro time might be better with PSI. Interestingly, in a study from our institution, we found that operative time was a little bit higher, maybe relative to the difference in learning curve, differences in surgeon practice. But the reality is, at least on this study, and I think what you'll see in a lot of these, there's no really change in alignment in PSI versus standard instrumentation. And then if you look at that for a low profile implant like the Infinity, again, you see that there's reproducible alignment with PSI, but it's no different than alignment from standard jigs. Patient reported outcomes, perhaps unsurprisingly, are very similar. And there's no consistent clinical superiority. Certainly, there's some signal for decreased fluoroscopy and decreased intraoperative guesswork that really hasn't borne out large scale yet. And so for me, the take home from the literature is that at the end of the day, when you're using PSI or standard, the alignments are equivalent. The sizing is probably variable, especially on the talus. The efficiency might be mixed. Maybe it decreases your fluoro, unclear advantage for OR time, and really no proven clinical advantage for outcomes. So when we take that all together, and if we know that to date, PSI and standard instrumentation has roughly equivalent outcomes, how do we think about them as tools that may have different values to us for our cases? And so this is where I think a lot of that level 5 evidence that Hodges Davis likes to talk about comes in. I'm not aware of any data looking at this, but please correct me if there's something out there that's new that I've missed. So this is all really kind of anecdotal that I found. So in cases of big deformity, for me, in these cases, standard instrumentation wins. And part of it is just maybe a trust issue. I just really don't think that engineers and PSI, they cannot balance the ankle for you. All that does is make your cuts. And so for me, what I like doing is I like understanding how the ankle will correct before I cut. What releases am I going to need? How is that going to affect where I resect, how much I resect, where I place my implant? How much bone should I take versus not take? How does my distraction to correct deformity play in? And these are the things that I feel like even the best PSI system and preoperative planning just cannot help me with. And as a result, I really like standard instrumentation in these cases. I also like doing the hard part of a case first, which is the balancing in these complex deformities. And so then the total ankle is just sawbones. Once you get your ankle in the place you want it, then it's just plug and chug. And similarly, for cases where you may intentionally not correct or overcorrect deformity, and I'll show you some examples of those, I actually think the best way to do that is with manually manipulating a standard jig. So this is actually a case given to me courtesy my partner, but this was a patient who had a valgus ankle deformity with immediately escaping talus as well as severe progressive collapsing foot deformity. And this was a case where my partner used PSI. And you can see that the correction is the alignment looks really excellent. But what my partner noted is that the PSI did not account for the laxity and medial instability that you see sometimes in these really intense valgus flat foot cases. So my partner ended up putting in a size 16 poly, which worked out fine in this case, but got lucky here. And because this was a little bit bigger patient, so there was an 18 poly available, but sometimes that might not happen. And if this is a smaller implant, you might not have that available. And so this is a case where my partner said if they had done again, would have done with standard instrumentation. And so I will show you one of my hardest cases in my career, which was a complication. So this was a patient who came in with a prior partially malunited, but then partially non-united triple, who then had ankle arthritis and a BMI of 40. So you can see a fair amount of soft tissue habitus. And so there were 1,000 things wrong. This could probably be 4 hours on its own. But what I'll show you is that, so first thing for me is after ruling out infection is to revise the triple and at the same time do a cement spacer in the ankle. Then I came back another day and did the total ankle, which I thought initially looked really nice. That's my intra-op fluoro that you can see. But then a few weeks later, patient comes back and the total ankle fails into valgus. And so for me, for this revision, major case of deformity, this in my hands is not a case for PSI. And so what I ended up doing was taking the patient back. And so I know the x-rays look totally wonky, but I took the patient back, did a fibular lengthening, did a first, revised my first TMT fusion with a graft deep implantar fixing the first ray more, put in recutting the talus to intentionally be in a little bit of valgus to retension the deltoid. And then on top of all that, also put in an internal brace of the deltoid just as a little bit of a backup. And so you'll see it's in a little bit of valgus intentionally so to retension that deltoid. So I'm not falling into even more valgus. And everything else there is pretty much a second seatbelt or a fail safe in case that doesn't work. So the x-rays look totally wonky, but I think she's now close to a year out and healed and doing well and stable. And so for me, this is a good time for standard instrumentation. So the next case, or the next scenario we'll talk about is challenging anatomy. And so for me, in this case, there actually can be benefits to PSI here. And so even if I still will use standard instrumentation, this is actually ones where I like looking at the plan ahead of time, because implant sizing, placement, and implant choice, whether you're a low profile user or a STEM user or a revision modular implant user, those are all things I really like to visualize and play ahead of time with the plan. Also, I didn't have a case for it, or I couldn't find my case of this, but if you're looking to put a low profile implant below the tibial nail, this is a great time for PSI to make sure you fit it in without needing to remove the nail. And that being said, it's still nice to play around with your implant position with standard instrumentation to tweak things, but I still like knowing ahead of time. And so here's a patient who's a more recent case. So this is an interesting one. He's 79. He's got a big post-traumatic deformity and some really interesting things here. So first of all, he's got big cysts. Second of all, he's got a really interesting medial to lateral mismatch of the talus versus the tibia. Look at where the center of the talus is versus look at where the center of the tibia is. Any implant is not going to line up normally if you just try to put it center in one of those. And then there's also a major talar versus tibia size mismatch. I think in the implant system I used here, the tibia was measuring like a 5 or a 6. The talus was measuring like a 3. And so you know ahead of time that it's going to be impossible to center your implant and get it perfect in both the tibia and the talus. So you know you're going to have to make some accommodations. And for that, I think some preoperative planning, which I played around with on the kind of the preoperative plan, was really helpful. And you can see some of those in the post-ops. So I don't think PSI is required here, but it was nice to play around with, certainly. So I templated a traditional stem versus a modular augmented. And ultimately, based on my pre-op plan, I knew I would ultimately pick the modular augmented. I also knew that based on his deformity, I would have to be in a touch of varus. Otherwise, I wouldn't be able to get this center. I also knew I would have to medialize my talus just based, again, where the tibia was versus where the talus. And I knew my talar size would look stupid. And it does. It looks a little bit oversized, but I chose that in order to accommodate my tibial cortical contact. So again, even though it looks a little funny, this was kind of where the implant had to go to fit this patient's deformity without doing a major kind of osteotomy, which is in a 79-year-old, I didn't feel like was appropriate. And so right now he's doing okay. I probably should have put in a medial mouse screw if I'm looking at it now, but otherwise things are looking good. But I think this is a case of anatomy where PSI was helpful. And then I'll show you just another one, a case where I didn't use PSI, but I wish I had. Not necessarily just because of PSI, but because of the sequence of events. This has changed in the new system for this implant, but wasn't available at the time. So this was a young woman. She's 44. She's a post-pilon arthritis. She had major anterior translation of the talus, and we see that anterior escape in these post-pilon injuries, but the talus won't go back with traditional releases. Like, you can release everything you want. You can cut that you can cut the entire Achilles tendon. Talus isn't going to go back. You need to cut the tibia first. And you can see, if you look at the path of where the drill is, otherwise the drill for a stem would be blowing back through the back of the talus and all the soft tissues there. So this is one where I ended up having to cut the tibia first. So you put the cutting guide on first without drilling. You cut the tibia. That actually allows you to reduce the talus. Then you can drill and ream, but you have to make sure the drill is perfectly centered underneath your tibial cut. Otherwise, your implant won't sit. And so this PSI would have been really helpful, just to cut first, then ream. So again, a challenging case and challenging anatomy where I think PSI would have been beneficial. And then just a tiny one, for sizing, I think this patient was like 4'11", 100 pounds. I don't think I would have gone to a custom implant here, but PSI can be nice because the implant can kind of only go in one spot for these tiny little ladies. So I'll just finish up with some random pros and cons. Again, I'm a standard user, but my partner, who's a major PSI user, really defaults now to an extra 2 millimeters off the talus. Otherwise, the joint was always too tight and they were recutting the talus too often. I think the PSI always oversizes the talus, pretty much always go one size smaller to avoid medial impingement or a stress fracture medially. Also, PSI, whether it's a bad plan or a bad guide, not sitting well, can really lead you to taking too much posterior bone off the talus. So my partner sent me a case of this. The implant has good cortical contact, but certainly the slope on the talus might not be exactly what we want it to be. And so just be careful of that when you've got PSI. And then just a final thought, I think a lot about rotation. I really don't trust PSI for rotational deformity. I think it's really hard to quantify. It's hard to visualize on X-ray and CAT scan. And I often find that they overly internally rotate implants on pretty much every PSI system. So whenever I do custom implants, you can actually see I screenshotted this. They write in like the captions where they take notes on what the surgeon likes. They say, prefer slightly more external rotation on axial alignment. I can say that's true for every case. So thank you all so much. Thank you for this opportunity. Love learning about this, love talking about this, and looking forward to speaking more.
Thanks, Jensen. That was excellent. So next up, we're going to go right to Dave, who's going to talk about periprosthetic fractures and total ankle replacement.
All right. Thanks, Jim, and thanks, Jensen. I'm assuming everyone can see my slides. Thank you for giving me the opportunity to be here. I think this is my 4th or 5th year on this virtual town hall, which I'm very excited to be a part of. So thank you, Selene, and all of the other people who've been behind such a massive effort. We're going to talk a bit about periprosthetic fractures around total ankle replacements. And honestly, it's not that hard of a topic to talk about because there's really not that much data on it. So I really appreciate giving this topic, having been given this topic, because I actually learned some stuff about it. So these are my disclosures. So if we just talk about the epidemiology of periprosthetic fractures, it's about 1 to 5% after primary total ankle replacement. And people think of it as the most common intraoperative complication of ankle replacement, the medial malleolus being the most common. And I think when we all, as surgeons, think about them, we think about them mostly as intra-op or post-op, and then stress or traumatic. If we look at risk factors, osteoporosis, intraoperative cortical breach, narrow medial malleolar bridge, revision total ankle replacement is, of course, a big one, and as it would be the case in the X-ray on the right, malalignment. Jim did a nice study, I believe probably when he was a fellow, looking at low bone density on preoperative CT scans. He looked at almost 200 ankles and looked at Hounsfield units. And really all of the fractures in that cohort occurred in patients who had CT scans with Hounsfield units less than 200. And if you don't really know much about a Hounsfield unit, right here, bone should be over 1,000. So that's pretty significant osteoporosis. So osteoporosis is clearly a risk factor for developing a fracture around an implant. And this is a clear example right here, a star that had some prior trauma. And you can see right there, even probably intraoperatively, which is the left picture. On the right, it just pulled right off the medial malleolus. And that is, I think, a good example of maybe that bridge was narrow, but certainly this patient is severely osteoporotic. Jensen did a nice study as well, looking at an additional risk factor, which was the narrow medial malleolar bridge and malalignment. This is a nice study in 2024, case control study, where they really nailed down the 10.3 millimeters. And there are certain things we talk about with patients, risks of non-unions, risks of a variety of things when we talk to them about surgical consent. One of the nice things to talk to people about or at least other surgeons, is when are you at risk for breaking the medial malleolus? Because I think that's a real intraoperative concern that we all have, and I know that I certainly do. And in this study, they suggested that you really consider ORF of the medial malleolus if the width is less than 10.3 millimeters. And really over 12, you were sort of in the clear. The fractures also had a positive association with the tibial component being in varus, which would obviously make sense. And ORF decreased these reduction by about 90%. Here's an example of an outside surgeon's x-ray. You can see this is an immediate post-op x-ray on the left, and that stem is in a little bit of varus, and you can see over time that obviously caused a stress fracture and then a complete fracture of the medial malleolus, which that surgeon did not treat. And now this is a complete implant that needs to be revised. So this is probably a narrow medial malleolar bridge on the left, but also clearly varus malalignment. Revision total ankle replacement is clearly another risk factor, right? When in the bottom left picture, you can see this is after a spacer from an infection. That medial malleolar bridge is narrow, and you're going to need to manipulate an instrument around this to put in another implant. So putting in fairly rigid internal fixation in that medial malleolus is going to be fairly protective. But you can see here on the right x-ray, there was a cortical breach of the fibula. What about classification? Well, we haven't been doing this as long as our arthroplasty colleagues have. So we don't have long developed classification systems that are really based on longitudinal studies and outcomes. But the most recent classification system by Hill and Brown in 2025 is what I've come to find is really available. They characterize 3 basic types of fractures. One was around the talus and the fibula. So that was A. B is around the tibial component, and we'll get back to that. And C is in the proximal tibia. So let's go through those a little bit more. So if we look at A, there's AF, which is the fibula, and AT. And these are not that common. Konstantin Dimitrakopoulos at HSS did a nice study looking at talus fractures around the talar prosthesis. In 2020, he looked at about almost 500 patients, and there were only 5 cases of a talus fracture. These were all implants where there was a stemmed talus. And it was all pretty much associated with poor outcomes. The take-home message was largely if you have a painful talar component or a painful ankle that really doesn't show, that it really isn't obvious why they have pain. A CT scan is obviously a nice study that will often show if someone does have a talus fracture, and the prognosis is relatively poor for that patient population. If we look at the fibula, there really is no data. There are just some isolated case reports. I think this is largely from small anatomy, maybe from oversized implants. I think in general, with the evolution of total ankle arthroplasty, we have been a little bit, I would say, we have not paid attention as much to the smaller population. We have plenty of big implants. We don't have as many small implants. And I think that in some cases, we're forced to almost use an implant that might be oversized. On the bottom left picture, you have a smaller patient with a ball and socket ankle. And I used a Cadence, the smallest Cadence total ankle replacement that was available for me. But I broke both the medial and lateral malleolus in that case. I cracked it intraoperatively, and I knew that, but that can happen. You can see on the right picture that someone, one of my partner's x-rays, who had fractured the fibula intraoperatively, that obviously needed to be fixed, but this can often also come from an errant saw blade. And that's an example of an errant saw blade when we're cutting the talus has then been distracted, so they're not aligning completely, but you can see that can sometimes happen as well, so we have to be a little careful. Okay, so let's go to the other side of the classification system, which is above essentially in the proximal tibia. Here's an example. It's relatively rare, and these are mostly traumatic and they're post-op. This is a 66-year-old male with psoriatic arthritis. He's on Xeljanz, which is a Janus kinase inhibitor. He had an ankle sprain 3 months out from his ankle replacement and fractured through the holes in the external guide. And so, I mean, it's a terrible complication, but this just needs standard open reduction internal fixation, as was done here by one of my partners in my absence. And that healed relatively uneventfully, but we just use standard AO principles for treating these types of fractures. Now, if we go to the type B fractures, this classification system characterizes them as around the tibial implant. B1 would be if the implant and the fracture are essentially stable, and that just gets ORIF. Similarly, if this fracture is unstable, but the implant is in good bone, also open reduction into fixation, and generally not need for revision. B3 is the case where things get a little bit more complicated, where it's an unstable fracture around poor bone around the implant. And that would often require some additional thoughts about how we would revise the implant and get fixation of the implant while also getting stable, rigid internal fixation of the fracture. Let's go specifically to the medial malleolus, as this is much more common than any of the other fractures that we've been talking about. It's thought to occur in almost 1 to 15 or 20 total ankle replacements. There is a study by Cottam in 2025. This was a multi-center retrospective analysis, but I would point out that it's a really small sample size, only 159 patients, that came up with sort of that rate of occurrence. I think in general, people think that ORIF, when recognized, right, certainly intraoperatively, there's no data on ORIF versus non-operative treatment. We can go, I think, from a lot of our colleagues in other areas of arthroplasty, whether there's the shoulder or the hip and knee. Most periprosthetic fractures are treated with open reduction internal fixation because the risk of ORIF is much lower than the risk of the need for revision if the implant becomes unstable. There are, of course, exceptions: greater tuberosity fractures in the shoulder, greater trochanter fractures in the hip. Those are not always treated operatively. But I would say that most medial malleolar fractures around an implant are not treated non-operatively. They are operated on. What about prevention? Like, what can we do? Well, going sort of towards Jensen's talk, I would say that ensure that your medial malleolar bridge is going to be large enough to accommodate the implant and also not put the medial malleolus at risk. So making sure that it's over that 10.3 millimeters. You can do that on your preoperative planning software if you use patient-specific instrumentation, or you can certainly even just template on an x-ray, as you can see on the top right. I think all the planning software is very similar and certainly does give you that medial malleolar measurement. You need to also use the pins and the guides, whether these are the pre-contoured guides or these are the external guides that are not patient-specific. You need to use those pins to protect the malleoli from an accidental cortical break, because that just creates a large stress riser that can be exploited during the procedure or even afterwards. Another comment I generally make to residents and fellows is do not dorsiflex the ankle without the implants, right? The talus will fracture the malleoli. And that's another way of just making sure that we don't, cause these iatrogenically. You must have implants or a spacer in there. So we have prophylactic fixation, right? If the medial malleolar bridge is less than 10.3, we know we're going to do it. If there's osteoporosis, we know we're going to do it. But how about for everyone? And what do we use? Well, prophylactic fixation has been looked at. The Duke group looked at this in 2014, a long time ago, 10 cadavers. They looked at screws versus 1/3 semitubular plates. There was really no difference. Greg Burlett in 2025 looked at non-metallic fixation. He is somewhat conflicted with that company, but otherwise the study is a good study. It was 150 single surgeon cases, which really showed no complications in the ORIF grip. The idea was, hey, medial malleolar fixation does often require medial malleolar hardware removal, and an absorbable implant doesn't, but protects the medial malleolus during the case. What about billing? I wanted to bring up billing. I talk a lot about billing. Can you bill for prophylactic fixation of the tibia? You can. There's a number of codes to consider, at least in the US market, 27766, which is ORIF, but there's also the 27745, which is prophylactic fixation of the tibia. The bottom right photographs are those of that absorbable or biointegrative implant. But either way, it's a decent number of RVUs. If it's intra-op, you add a 59 modifier as it's a separate service. If it's post-op, most people use a 78 modifier, which is an unexpected return to the operating room within the global period. Here's a case example. So this is a 71-year-old female, total ankle replacement, uncomplicated, star. Follows up 2 weeks later, post-op pain with left knee and ankle pain. Okay, so post-op follows up, states no injury or non-compliance. Okay, they have a medial malleolar bridge of 12.3 millimeters. They have a medial malleolar fracture and a lateral tibial plateau split depression. Okay, so take back to the OR, ORIF, subsequently find out from the family she has multiple personality disorder. She sleepwalks. She fell on the left lower extremity. Okay, so some things you can't prevent. Sometimes the lives that we live and interact with patients are a little unpredictable. But in this case, this just required standard decision making as far as open reduction to fixation. So in summary, this occurs in about 1 to 15 to 1 in 20 patients. Note that 10.3 millimeter bridge. I think that is an awesome number to keep in mind. Protect the malleoli when you're cutting. Consider prophylactic ORIF in those at risk. Most fractures do require ORIF, and the guidance is evolving. So thank you very much.
Thank you, Dave. Great talk. So now we'll move right over to Andrew, who's going to talk about cases where he wished he hadn't done an ankle replacement.
All right. Thanks, Jim, and thanks, Selene and Alan, for hosting us. Dave and Jensen, great talks. So Jim wanted me to kind of give a talk on some of the ankles I maybe wish I didn't. These are basically just a couple failures. This will be kind of a quick talk, and then we've got some great cases to go through with Jim. As far as my disclosures are concerned, here are some of them listed. Most of these companies probably don't want to be affiliated with me after this talk, but I think the biggest disclosure is, please note this is not exactly my best work. And unfortunately, there's a lot more where this comes from. So now that being said, I just wanted to give this talk because there's a lot of us out there. I'm in my 7th year of practice. So I still feel like I'm evolving into it in my surgeon career. And I think a lot of us experience this, and things we need to talk about and be open about and learn from. Like Dr. Parekh had mentioned in the beginning there, when we're making these mistakes and we're having these complications with our patients, we're not alone, but we need to be learning something from each and every one. And it's sort of, how do we take those lessons and apply it to our next patient? So this is a first case here. This is a gentleman that came to see me. He's a 52-year-old male. He's a gentleman from Mexico, and he had a previous scope debridement at some point. Clearly, you can see some arthritis throughout that ankle, a little bit of varus deformity. He's a fence builder, so he's not the biggest laborer of all time. He's not doing heavy lifting, running, jumping, anything like that, but he certainly is on his feet. So he comes to me. He's looking for a total ankle, keeps telling me he really wants to preserve motion. He's reviewed a lot of literature on his own, and he's very, very interested. But here's a CT scan, so I get a scan of him. You can see here some cystic changes in there. You can see some of that varus deformity, but nothing really too concerning that's going to make me jump towards doing a fusion versus doing a replacement per se. But as it turns out, as a lot of us have, we have patients that come to us a little bit prematurely. His A1C is almost 9%. He's not neuropathic, but he is a daily tobacco user. So as many of us do, we kind of send him on his way, conservative treatment. 90% of the time, as we would all agree, these people probably never show back up, can't get control of their lives, so to speak. Well, not necessarily the case with this gentleman. So he comes back to me. It's about 2 years later. He has completely quit tobacco. He's gotten his A1C under control, and he's still not neuropathic. Now, because of insurance issues, he's gone to probably 4 or 5 surgeons within the area, and they all have told him that they will only do a fusion on him. A lot of them are pointing towards the fact that he's a quote unquote laborer, and then also just because of the fact that he, had the previous issues with the tobacco. But if you're like me, sometimes you figure, hey, I'll take a shot at this, and we'll see what happens. And as you can see, not always my best decision. So took him back to the operating room, did a fairly, what I thought was a fairly good ankle replacement. I was quite happy with that. Got a lot of the correction of the varus, like Jensen had mentioned in her talk. I tend to do this. This is obviously an M-bone, so I tend to do it with Big Bertha. Felt like I got a good correction through it, and I felt pretty happy. Unfortunately, as luck would have it, he comes back. He's got an open wound, completely open at this point. This is going to be several weeks later. I try managing it early on, and it just completely starts falling apart. So again, things can't get any worse. Of course it does. He ends up having a stroke, and I'm actually at one of the winter meetings, and I get a call from his daughter. He's at an outside hospital. He's had a stroke, and they absolutely will not clear him under any circumstances to undergo any surgery. So I have to sit there and try to manage this wound locally with the wound center for several weeks before we can finally get him back for surgery. And, as you can imagine, I go back, I wash him out. I ended up keeping the implants. I'm not that was not the worst, decision at this time. Ends up getting a flap. He ends up healing that. But again, I've got this guy, who's in his 50s, and now I'm staring at this ankle. So this is his most recent, one of his more recent x-rays. You can see implants are still in. You can tell he's got an equinus contracture. He is as stiff as a board, cannot move this ankle at all. He's the nicest guy. We've got a great relationship, but I wish I had done something different. I wish I had done something that would be better for this patient. When we look at outcomes with ankle replacements, obviously there's a lot of us on this panel, probably all of us, that are biased towards ankle replacements. We know the way that it can really improve a patient's life. We know the studies show improvement in range of motion, mobility, and functionality, and there's the risk for decreased adjacent joint arthritis. These are all things that push us to be a little bit more aggressive with taking care of our patients when it comes to doing ankle replacements. The problem is none of that really matters if you get a bad complication. So all of that goes out the door if we're mucking around and we're going to make these people worse. So with this case, I learned, you got to choose your patients carefully. These complications will completely erase the benefits that are made to be from the ankle replacement themselves. And this guy was very adamant. He wanted to preserve motion. We often hear that. We love to hear that. Great. I really don't have to do an ankle fusion now. I get to do the replacement, but we got to do what's best for our patient. Some of that, a lot of times, that's us putting our ego to the side. This is a second case. This is a lady that came to see me. She's a 67-year-old female, pretty low activity level. She ambulates, she uses a walker around the house sometimes. She does have a history of MS, probably a cane occasionally, but she's not doing anything more than that. Again, she comes to see me. I'm pretty excited. I go, oh, great. I got another great ankle replacement. There's not too much deformity. Obviously, we can see that syndesmotic widening. But other than that, pretty well aligned. So I feel like, okay, this is kind of going to be a slam dunk. I feel pretty good. I'm booking this case for surgery. I'm pretty early on in my career. I feel like this is going to be a great case to get through. Well, and this goes back to what Jensen had mentioned in her first lecture this hour, looking at sort of that tibial and talar mismatch. Really screwed me on this run, right? So I knew there was a widening of syndesmosis. A lot of times when we see that, though, you're going to see some gap in between. You're going to get some tilt in that ankle joint, so you can get some varus valgus. You're going to have some room to kind of play with that talus. But again, just like Jensen said, I was young and dumb. I didn't really appreciate as much the mismatch ahead of time. PSI probably would have been very helpful for this. So you can see the mismatch between that talus versus the alignment of that tibia itself. So it's going to be hard to get that talar alignment perfect. And of course, as luck would have it, as the total ankle gods would have it, right? So I've got this ankle and I'm trying to balance this talus underneath. Now that talus looks kind of balanced there. That is a mirage. Basically what happened was I had to really shuck that talus over to be lined up with that tibia. And as a result, I really had to debride a lot of that talus on that lateral side. So what happened was intraoperatively, I was sliding out. So I was basically subluxating out laterally. So I took everything out. Obviously you can't see this on the x-rays, and I wasn't in the mood to take any pictures at this point. So take out the poly, I tighten up everything medial. Her soft tissues are absolute garbage. I end up putting an internal brace medially, and I get it balanced, and I feel pretty good. Actually, I didn't feel pretty good, but I was hoping, praying. And this is the kind of case that you're sitting there for the next 2 to 3 weeks, just waiting for them to come back in the clinic. Well, of course, she comes back to clinic. She's completely subluxated, ripped out that internal brace. So to make things better, she's also healing like trash. And so unfortunately, I've got a wound, I've got a subluxated ankle, and now I'm dealing with a problem here, a really, really big problem at this point. So take her back to the operating room, take out her implants, spacer. I basically treat this like an infection, as you would imagine. I use as much use as much soft tissue mobilization to close her anterior incision. I've got this sort of medial gap skin, vac. I get involved with the plastics team. We actually let this, because she's just a poor candidate, let her heal basically via secondary intention. We get this to heal with the spacer while she's getting her IV antibiotics over several months, and then end up going back and doing a caged TTC on her. So, of course, this could have been solved. She's a pretty minimal ambulator. She doesn't do much. She told me the magic words, I want to preserve motion. in her head, she had some miracle in mind, and so did I. And, I got talked into it. Now, for those of you that know Jim Nunley, when I'm showing this case in conference, he's quite clear that I did a terrible job there. So, that comes with the territory with us doing these total ankles. So this is, the kind of the thing I learned here. There's a learning curve. There's a really is a big learning curve when it comes to doing these total ankles. We know if you look at studies, there's a couple meta-analysis and a couple randomized or a couple good studies, retrospective studies that show that with time, your operative time goes down, your revisions go down, your outcomes improve. There's definitely debate in the literature what that learning curve exactly is, 25 to 50 cases. I would definitely say it's probably at least 50 cases. Now, the question becomes, how does that compare to our hip and knee partners? Well, I think it's definitely greater. I mean, if you look at some of the hip and knee literature, they talk about the learning curve being 80 to 150 cases with knees and hips and things like that. But you got to put into perspective how many of those they're doing a year. You can easily become not an expert, but you're going to cross that learning curve as a hip or knee surgeon within your first year of practice, second year maybe at worst. How long does it take a lot of us to get to 50 cases? It takes a while. It definitely took me a couple of years before I broke 50 cases. So the learning curve is going to be there. It's certainly real. You need to rely on your whether it's your PSI, your colleagues, your experience, whatever that may be, but just something to be aware of. And then this is the final case. So again, this is a lady that comes to me. She's a 59-year-old female. She's retired. She lives out of state. She is flown in. She's a bit affluent. She's flown in. She wants to come to our facility. She's very, very active at baseline, nothing high impact, but if it's not high impact, she's doing it. She's doing it every day. She's got pretty good range of motion, actually, which is a little bit shocking there, but she's got pretty good range of motion. She's actually, here's her CT scan. So she's got, a little bit of bone loss or a little bit of cystic changes in the back of this talus, but again, nothing real crazy. So the problem is she flew out and she got on my partner's schedule, one of my very, very experienced partner's schedule, but unfortunately he's booked out and she wants it now. She absolutely did not want to wait. So she presents, she shows up in my clinic. She's ready to have this ankle done. We all know this, some of us younger faculty know this feeling, but, I felt pretty confident that I could give her a good ankle. So I take her to the operating room. I put an ankle in. I feel pretty good about it. Hindsight, I don't, but feel pretty good about it. Talking about, Dave talking about the medial mal. I'm pretty protective of my medial mal. I definitely undersized her here on that front to back. I'm a little bit open down that tibia, but otherwise I feel pretty good. Pretty minimal resection. I feel pretty happy with how this goes. Now, with her living out of state, follow-up's a little wonky at times. We're talking quite a bit. She comes back for her 6-month post-op, and she is extremely painful. And as I start talking to her and starting to get some of the story from her a little bit more, I find out that about 3 months after surgery, she ended up going on a 2-week backpacking trip out of the country. So not super happy. So there's a little bit of me, a little bit of her involved in this one. So I get x-rays and I get a CT scan, and that tibia is just loose. So pretty frustrating at this point for sure. So I take her back. She's extremely loose through that ankle. End up having to do, obviously, a lot of you are familiar with this big revision type implant, and Jensen showed a couple as well in her talk. So now I've got this, late 50s, super, super active lady that showed up to me like that on the left, and now I've got this big revision implant in her in less than a year, and it just kills you sometimes, So it's real. These complications are absolutely real. They can happen to a lot of us. For me, for this case, I try not to, and I'm not knocking low profile implants by any means. I still use them. I definitely err towards some of the stemmed implants like Jensen had said. So sometimes I feel like you got to just do the right thing the first time. Give them, the patient, their best shot the first time. A lot of times I think we're struggling with, well, what are we going to do down the road? And how are we going to salvage this if this goes bad, which I do not think is wrong by any means. But sometimes you got to understand your patient's activity level and what their bone is. And I definitely underestimated her activity level at that time. And I probably should have gone to a more stout implant. So in conclusion, the learning for me, these are the things I've learned over the past 7 years. The learning curve is 100% real. I'd love to say I'm over it, but I'm not sure I quite am, even though I'm way past 50 at this point. I'm still learning. You need to be honest with your patients, but more important, you got to be honest with yourself. You need to be able to put your ego at the door. And if they don't need a total ankle or they need something different, you got to have that conversation and got to be able to accept it. You got to be able to recognize and plan. Again, that comes with time, that comes with experience, and that comes with leaning on the people that trained you as well. And you got to give your patient really their best shot the first time. So wanted to keep that quick so we could get to Jim here. But again, thank you. I appreciate everyone here. I've had a lot of mentors along the way to get to me to this point, even though they probably don't want to admit it. And here's Jim and I, Big Sky. We cut out a few people in that picture. They're definitely the better skiers than Jim and I were. So thanks, everybody.
Haven't skied again since. All right, so we do have some cases, and hopefully everybody enjoyed those talks as much as I did. So we'll get right into the cases. We have about 12 minutes to get through these, and so I'm going to try and breeze through the first one, and then we'll get a little bit more interactive with the second one here. So this is a patient who came to me with a pan-talar fusion. She had it done in Puerto Rico about 15 years before she came and saw me. And, just to, I don't want to belabor this case because I certainly made it a labor. But this screw that's broken really ended up being a problem, right? So getting that broken screw out proved to be a real issue. So I got the proximal segment where the head is, obviously. I got that out relatively easy, but I could not get this part that crossed the joint out at all. And so you can see on the left side of the screen, I had to essentially break it out. So I broke the chaput part of the tibia. I broke the fibula on its way out. It really was a wrecking ball as it left that ankle. And then in order to get that medial to lateral screw out, I had to sort of dig a little trough in that medial malleolus. So, this is back, I want to say this is probably 5 years ago at this point, maybe 4 years ago. We'll see. I'll have a follow-up x-ray that was just a couple of months ago. And I don't use stems that are this long anymore. I think this is too long a stem. I don't find any reason for this. But in this case, I had a fracture that went up above the chaput area of the tibial plafond. And so I thought I needed to grab some bone. And by shoving that into the tibia, that fracture in the chaput area propagated and it kind of went up the shaft of the bone. So just like you would do if you were putting a hemi in and you crack the calcar, you have to see the end of the fracture. And so I went and opened my incision a little bit higher. I went all the way up and I just put a couple of cerclage cables around this. Also, during that surgery, broke the medial malleolus. So put did a number on this. Here's a couple of, x-rays that show a little bit more detail, a little bit closer up. And so fixed the fibula fracture, fixed the medial malleolus fracture, fixed the chaput fracture, fixed the tibia fracture. So Dave asked us if we had any cases that we could share with him for his presentation. And I guess he's probably now thinking that I held out on him because this was certainly some periprosthetic galore. But anyway, this is obviously a patient who now is 4 years post-op, and all of those fractures miraculously healed. She did end up, because of one of the clamps, or I guess the clips on the cerclage cables, she did end up rupturing her extensor hallucis. So she all of a sudden, maybe 2 years after the surgery, told me that she couldn't extend her hallux, and unfortunately developed like a hammering hallux. And so I ended up having to do a Jones procedure. I didn't do a Jones procedure because the EHL was that I actually just fused her first MTP joint. A podiatrist had actually fused her IP joint about a year before that. So even the ankle is doing okay, but she's in my post-op period now for that first MTP fusion. So anyway, how you can break as many bones as possible while you're putting an ankle replacement in. But 4 years out, I think she's pretty happy. She still has some flexion and extension, which, with that pan-talar fusion that she had, she's still giddy about this. And I guess the further and further we get away from the surgery, the better and better I feel about it, but didn't feel good that day. All right, so this is a patient, and I want to get the panel's opinion on. This is a patient who had an 18-month history before she came and she was referred to me. There's a surgeon in New Jersey that I've become friends with. He doesn't do many total ankles, so he sends a lot of these patients to me. And I guess one of his partners had done an ORIF, and it had gotten infected, and he sent him to my friend here, who put an X-Fix on, washed everything out, took everything out. And, this is kind of a summary of her history. So she had the ORIF of her ankle in April of 23. Wound dehiscence infection, attempted suppression for a while, but they continued to have wound problems. So the hardware was removed. An X-Fix was put on because the ankle was still unstable at that point. And the X-Fix stayed on for quite a while. It stayed on until October of that year, where they removed the X-Fix, continued some wound care. The wound was finally closed by January. So, lots of time is passing here where this patient is not weight bearing, right? So there was concern by ID in January, even after the wound had closed, that there was still some continued swelling. The labs were kind of mildly elevated. So I don't know what the delay was here, but the patient underwent an IND in 2024. So we're more than a year later. The patient still hasn't walked on this ankle, and did an IND with cultures. And I'm talking about like 25 cultures, bone cultures, everything. Everything was completely normal. And so he sent her to me because she did not want a fusion. Just like Andrew said, that certainly doesn't mean that you don't get a fusion, but and people who don't want a fusion, people who like to do ankle replacements, tend to try and really weigh whether or not they can do this. So anybody on the panel, what do you think about this patient as an ankle replacement candidate? You have a non-union of the fibula, non-union of the medial malleolus. You have what is the most disuse osteopenia you can ever imagine on a foot, because it's been almost 18 months since she started walking on it by the time she's going to have this ankle replacement. What red flags do you guys see?
Well, I'll just jump in. So for me, this is not an ankle replacement, not because you can't do it, but because this patient has had already so many surgeries that the one that I can offer her that involves a replacement is a highly risky surgery for her, potentially limb threatening given how much surgery she's already had. So for me, this would be a fusion, and not even a straightforward fusion. I explain to patients in this situation that you have two bad choices. You just have to choose which one's better for you, right? Neither option is good. And this is a real salvage procedure. So patients need to really understand this. And I think patients generally underestimate the risks of these surgeries in their own mind, despite what we tell them. So for me, this is not an ankle replacement.
Yeah, I agree, Dave, 100%. Now, the other thing is stiffness. This patient's got to be as stiff as a board. And I think some of my worst outcomes, and I think we would all agree, have been in patients that are stiff, and we've tried to sneak in an ankle. Maybe it looks good in the operating room. They're going to stay stiff. We know this with the data. I agree. Bone quality is crap. Now, say you wanted to play the game, you're going to have to do something. I mean, the other thing that would make me nervous is that non-union. The fibula is probably pretty stiff, to be honest with you. That doesn't bother me, but that medial mal would. If I was going to play this game of trying to do an ankle, I probably would tell her I'm going to try to get that medial mal united first before doing so. But again, this is a nail for me, and it's actually I would probably err on the side of doing a antibiotic nail first. Even if you're telling me culture stuff, I'd say, listen, I don't care. You've been dealt with other people. I'm shoving a nail up with antibiotics and treating you with antibiotics for a few weeks, at least make myself feel a little bit better.
Okay. So here's that. I hear what everybody said, and obviously in hindsight, we'll say that you guys were probably right. But I didn't feel comfortable when I saw her in October of 2024. I didn't feel comfortable with her bone quality, so I actually wanted her to walk on this, and I wanted her to walk on this just to try and at least wake this bone up a little bit. And I thought that maybe 6 weeks of doing that would be enough to start seeing some change in her. But those x-rays that I showed you were actually the x-rays from after she had started walking on it. So still not great in bone quality. I didn't get any feedback at all from the saw. The locking Morse taper was difficult because as you're trying to use that wrench to, be the backbone of your impaction, the wrench was just digging into her tibia. And so it was really a bad feeling there when I was actually trying to lock the Morse taper in. And so here I am going to fix her fibula, and you can see that the Morse taper was not actually locked in, right? So even after I thought that I had gotten this implant in a pretty good position on the right side of the screen there, maybe a little bit medialized, but once again, I'm not using very long stems so that I can put this center of the ankle in the center of the tibia. Anyway, I thought I had it in a good position, but unfortunately the Morse taper hadn't locked. And so I continue fixing the fibula, and then I have to go back in and I have to re-impact the base plate. And since the bone in the front of the tibia wasn't really worth a damn, I had to put this kind of buttress plate in there. And so I put a horizontal buttress plate in, and that allowed me to at least slap this against this buttress plate. I also put a blocking screw in to prevent this thing from going into varus, because I added another stem piece, as you can see here, because once I pulled this thing out, I couldn't get it to be fixated back in where I had it before. And then, the medial malleolus, I don't really feel great about that fixation. You guys had some concerns about that, but I did her 2 days before Christmas, the December 23rd of 2024, and I drove down to Charlotte literally that night just thinking to myself, why did I do this? Why did I volunteer for that type of surgery? But this lady has done remarkably well. Andrew, I don't have the flexion extension views, but I will send you those. I don't know how much motion she has off the top of my head, but I actually think that her motion is not terrible, and she's pretty happy. It took her a long time. She was not happy up until about 6 months after the surgery, just because this was a foot that she hadn't really walked on for 2 years. But I think now that she does have some motion and she's able to get back to her activities, I don't know. You certainly could argue that this didn't go very well, and so doing a fusion would certainly be an option. But and obviously time is going to tell whether or not we have any further problems for her. But her bone looks like it's awake now, a year later.
Looks good. She's running marathons.
Yep, we have 3 minutes, so let's do this one. I'll breeze through this one. But anyway, this is a patient with chronic ankle pain. He had a talar neck fracture years ago. You can see kind of large cystic changes in that talus. And so he came to me after like 4 other people offered him a fusion, same type of situation. He asked me, do I think I could do an ankle replacement on him? So I told him I would have to do this staged. So I removed all the hardware. I located this cyst. I drilled into the cyst, and then I started using this, come to me curettes to really get rid of that cyst. I took some bone graft from his iliac crest. I filled that in his talus there. I also removed the osteophytes in the front of his ankle. I fused his subtalar joint because he had really, really bad arthritis on that CT scan. This is where that cyst was. And then I guess if you take a look here, I tried to get rid of the osteophytes in the front of his ankle in the hopes that I might be able to and get rid of his impingement, so give him a little bit of ankle range of motion back. And I was hoping that I didn't have to do an ankle replacement, but this guy had his mind set that at 4 months after our surgery, once his subtalar joint fused, and here's just for people who don't like single shots of fusions, this is a fusion showing the bone graft actually took, so we're coming to it right about now. Here you can see that bone graft actually took in his talus. So this is a talus that I actually think can accept a talar replacement, or excuse me, talar replacement, a talar prosthesis. And so anyway, this is the before and afters. Not exactly the same shot, but very similar. I thought I captured that cyst and had filled it in nicely. So I end up doing a relatively straightforward in-bone on this guy. So relatively straightforward stemmed implant, and really was feeling good about it for about 6 weeks. And then at the 7th week, he was playing with his motorcycle. I don't know, dropped his motorcycle on his leg. And fortunate enough for me, I was in Miami on a golf trip, and my partner actually had to fix this. So just like Dave said, he was away when his partner had to fix that periprosthetic fracture he showed. My partner, my pediatric orthopedic surgery partner, who does a lot of general orthopedic surgery, put this plate in. There was also a small Shaput piece here that he had to use this screw down by the ankle joint. And unfortunately, this guy didn't listen again. So instead of playing with his motorcycle, he was walking on it when he came and saw me to take his stitches out after this surgery. And so kind of fell into a little bit of varus. All the screws broke. And this guy, I have not seen this guy since his 1-year follow-up visit, which is what we're looking at right here. So periprosthetic fractures, even long after the surgery, they're the gift that keep on giving. So there's a bunch of complications for you, Selene. Hopefully this session kind of covered what everybody wanted. Does anybody have any questions? Alan, did we have any people type in?
Yeah, so thanks a lot for sharing all those great cases. There is a question from the audience. How often do you guys see CRPS? And but is that some indications or some like before you want to do surgery, you can sifting out those kind of patient?
I mean, I see CRPS. I don't like seeing CRPS, but it ends up showing up. And I would say that in my own practice, I probably see 1 or 2 patients every 2 years, probably that have postoperative CRPS. But I see patients that come into my practice looking for advice on CRPS. But yeah, not a huge part of my practice. Does anybody else have that experience?
Agree. Same numbers with you. I see it more with other types of surgeries more than total ankles.
Yeah, it's actually kind of interesting. I think total ankle is just so unique in that, unlike a lot of our other joint replacement partners, so many of our patients have had prior surgery before they come to us. And so, we're often dealing with consequences of that. amazingly, I haven't seen, I agree 100% with Andrew. I haven't seen it as much in ankles. And of the patients who've had CRPS of the ankle, who then I've operated on, you know, ideally after optimizing them with pain management and lumbar sympathetic blocks and gabapentin and like all the things, I actually found that the total ankle patients of all the CRPS foot and ankle patients tend to do a little bit better. Like I have a really great patient who had bad, you know, bad pilon, let's say, post-traumatic arthritis and some like post-op kind of neuropathic CRPS symptoms. And she was always very clearly able to delineate the difference between her CRPS pain and her ankle pain. And so, you know, she was one of those people who after surgery, she said, yeah, I'm not normal. I'm not 100% better, but she's like, at least my ankle arthritis pain is better. I still get my burning, my temperature sensations, but at least my ankle arthritis pain is better. And so I think for you know, CRPS can be challenging, and sometimes there is a very strong mental component to it. And so really for me, it's the patient who can get a total ankle with it or with a history of it is someone who can delineate it well, like that patient did.
All right. Okay, thanks again. Thanks for great cases and a great start to kick off the 2026 complication cases.